Welcome to A to Z of palliative care.
Hello, doctor. Hello, viewers. In our last video, we saw that we should inform the patients about their serious illness, provided they wish to know about it. Doctor, now what happens to the tests and scans? I guess that would continue. Am I right?
You are partly right. See, when I say partly right, the test and scans are to be continued depending on why are we doing the test and scans. See, we are talking about the people with serious illness. And if we are talking about the serious illness at the late stage, where unfortunately we can't cure the problem and we can only make people comfortable. In those situations, I repeat, only in those situations, tests and scans may not be needed. One, as frequent as we did earlier. Two, may not be needed at all. It's entirely depending on the physician or the doctor's clinical diagnosis, because we are not going to make any changes in the treatment depending upon the scan results or blood results. So if I want to discuss generally why do we do blood tests and scans, in two situations we do that. The first situation, let's say a person come up with a problem and the doctor doesn't know what the problem is, merely on examining and getting information from that particular person. Then we need a test to find out what the problem is. This is the first approach. We need definitely tests and scans to diagnose what the problem is. The second approach is on getting information from a person on clinical examination. The doctor or the physician knows what the problem is, but the doctor needs some supportive tests or the scans to confirm what he or she thinks that is right. So overall, either you need to do a test or scans to look for a diagnosis which we don't know clinically, or the second situation, we know already, but we want to confirm as a supportive evidence. In people with serious illness, in their last stages, particularly unfortunately if they are not curable, in those situations, unfortunately we don't have these two situations. Then getting information from people and examining the people clinically, we can come to a conclusion. Unfortunately, they are deteriorating. So with the primary aim being keeping them comfortable, I don't think there is a massive role in doing the test or scans at this stage.
Good. So you had given three scenarios and you explained it clearly that the final stage, if they are in the final stage, it is not really required. And we should do the best to make them more comfortable. Yes, doctor. Then in that case, what about the blood sugar level if they are diabetic? Well, we need to control it all the time, isn't it?
Again, I would say it's a bit tricky to say we need to control it all the time. Because when people are in the final stages where the diabetes, let's say, had gone into lots of complications and people are deteriorating, as a palliative care physician, we don't need to have a tight control of the blood sugars. So we can relax the range of the blood sugar control. We don't need to worry about in points to get the tight control. The only reason we still have to control the blood sugar is certain blood sugar levels, when it goes down, or when it goes higher than particular level, it can make people to have more problems or the symptoms. So again, controlling the blood sugar at this stage is to control the problems and not to have the tight control of blood sugars. If you want numbers, because we don't treat the numbers, we treat the whole person always. But if you want a guide in terms of numbers, that control of the blood sugar levels when people are in the last stages of their life, unfortunately, with diabetes and massive complications, or if we are talking about millimoles per liter, as in UK, it is from 6 to 15. So we should aim not less than 6 and we should aim not more than 15. If people are in UK and the unit is millimoles per liter. If we are talking about people in India, they talk in milligrams per deciliter, then it comes to not less than 108, that is 108, and not more than 270. So if people who are diabetic in their last stages of their life, the control should be between 108 and 270. There's no need to worry about tight sugar control at this point of time.
Which means if they feel like having a sweet, they can go ahead with that.
As a palliative care specialist, I would say yes.
Okay, that sounds sweet. At least during the last stage, um, they get to enjoy whatever they would like to eat.
Yes, because the only reason we worry about tight sugar control is to avoid complications. So for people who had developed complications already when they are in the last stages of diabetes, very tight sugar control is not going to help them in any way. But talking about keeping people comfortable, that's half of a sweet or a pinch of a sweet will make them very comfortable.
Yeah, they get to enjoy.
Yeah.
Those small changes make big differences at a very difficult and later stage. Wonderful, doctor. Thank you so much. Thank you, viewers. We'll catch up in our next show.
Thank you.